The per member per year costs were calculated in consultation with the state's actuaries using base data from the state's actual 2013 experience for Medicaid members aged 19 to 64, excluding maternity costs for those members aged 21 to 64, but including a pharmacy component, net of federal and supplemental rebates. As you see on the chart, anticipated federal revenue for the first 6-month period there in fiscal year 2016 is $664 million. For the next 12 months, state fiscal year 17, federal revenue is anticipated to be $1.39 billion with a $35 million state cost. And then the final 6 months of the pilot period shown on this slide, federal revenue is projected at $728 million and state costs at $38 million. The table shows enrollment growing over the course of the first 3 fiscal years shown here in the program. We anticipate a steady pattern of growth over the 2-year period, starting with an initial enrollment of 280,000 in fiscal year 2016 and gradually reaching 307,600 in fiscal year 2018. These enrollment estimates are in line with projections from the Robert Wood Johnson Foundation, and the enrollment growth pattern is consistent with estimates published by the Kaiser Family Foundation. For the anticipated first year of the pilot, as we mentioned before, calendar year 2016, which crosses the first 2 fiscal years shown here, the federal match rate will be 100%. In calendar year 2017, the federal match rate will be 95%. The base data costs that I mentioned from 2013 were trended forward using information from both the state's Medicaid experience and projections from the CMS's Office of the Actuary. The year 1 PMPY, or per member per year estimates, also assumed pent-up demand for people receiving insurance coverage for the first time of 5.4% in year 1, and it's assumed to moderate to 2.7% in year 2. A single per member per year calculation was used for both the Healthy Incentives Plan and the Volunteer Plan, as payments under the Volunteer Plan cannot exceed the per member per year cost of the Healthy Incentives Plan. What you see here is a weighted average of per member per year costs for projected enrollees based on age and gender, and the weights were computed using the actual mix of newly eligible enrollment observed in other states. And next slide, please. We feel like it's critically important to note that Tennessee is a recognized leader in using managed care principles to bend cost trends while offering members the benefits of partnering with large private and not-for-profit insurers. The results are impressive, as the state was recently shown to be tied for 4th lowest per capita spending in the nation, according to a recent report from the Government Accountability Office, or GAO. TennCare's projected medical inflation is less than half of national Medicaid and commercial average trends. Our trend, as you see here, is 3.3%, compared to national Medicaid trends of 6.7% and commercial trends of 6.8%. Those cost trends remain well managed over time through a review of utilization patterns and expenditure data, care coordination for members with chronic health conditions, and medical reviews to ensure that members are receiving the care that they need in an efficient manner. Dr. Long will continue to share more information on how the state intends to continue to control costs while maintaining a high quality of care for the patients we serve.
So as you see in Casey's slide, we've had a great deal of success in managing our healthcare inflation trend in the TennCare program to levels that are definitely superior to what you would see in Medicaid nationally or commercial insurance nationally. And we've accomplished that through our very mature managed care model with the aggressive use of utilization management. But these techniques, these utilization management techniques, are built around the reality that we've been operating in a fee-for-service world that rewards providers for volume. The more procedures that are performed, the more tests that are performed, the more hospital beds that are filled, the more money providers make. And we then manage utilization by essentially viewing the provider's behavior as a problem we have to solve for. So we implement procedures like prior authorization in an effort to try to weed out overprescribing or unnecessary procedures that can sometimes be commonplace in a fee-for-service structure. And while we've had success in doing that for almost 10 years, as our trends would illustrate, we recognize that most of the low-hanging fruit and even mid-range fruit is long gone. And if we're going to continue to control our cost growth trends, we're going to need to make some fundamental changes that move us away from this system that rewards volume to a system that rewards value. And by shifting to a system that rewards providers for delivering high-quality care in a cost-effective manner, you're really engaging providers or incentivizing providers to be a part of the solution rather than being viewed as this problem that the insurers have to solve for. Almost 2 years ago, when Governor Haslam announced his desire to try to find a Tennessee-specific alternative to traditional Medicaid expansion, he pointed to the fact that aligning provider incentives through payment reform would be necessary. It would be a foundational element to any coverage expansion because of the impact that it would make in the financial sustainability of whatever plan he brought forward. Our payment reform efforts are now well underway, and they're critical not only to the success of Insure Tennessee, but to the financial health and sustainability of the much larger TennCare program. This next slide illustrates the point that we're certainly not alone in recognizing the need to fundamentally change how health care is paid for in the United States. This is data from the Catalyst for Payment Reform, which is a national organization of primarily large employers who are purchasers of health insurance for their employees. And they've been partnering with health insurers to encourage a shift from volume to value-based payment. And as you can see, in just 2 years, there's been a shift from 3 to 40% value-based payments in the commercial market that this slide represents. So it's very clear that transformation of the healthcare system through payment reform is well underway in multiple sectors, and given our early start on implementation, we're well positioned to experience the benefits from both a quality standpoint and a cost standpoint. My final slide provides a very high-level depiction of what the 3 primary strategies in our payment reform approach look like. The first focuses on the delivery of primary care, and it seeks to reward providers that do a particularly good job at keeping patients healthy, that see to it that preventive care is delivered, and that manage chronic illnesses over a continuum of time so that you reduce the likelihood of acute exacerbations that lead to hospitalizations and or the development of complications that can result from chronic conditions. The second strategy focuses on managing cost and quality in association with acute healthcare events that we refer to as episodes of care. Ideally, you have fewer of these events if you have a strong primary care system where you're rewarding primary care providers who keep patients healthy. But many of these events are not preventable, and they represent a large percentage of our spend in healthcare. And so this strategy seeks to reward providers who manage services across the entire healthcare episode, resulting in the delivery of high quality, more cost-effective care. And then finally, the third component of our initiative focuses on long-term services and supports. This is still where a large percentage of TennCare dollars go, to nursing facility care and home and community-based care. And up until this point, like all the other aspects of care, this has been a volume-driven reimbursement methodology. We pay for how many days you're in a facility. Under our payment reform initiative, we're moving to quality and acuity adjusted payments. And with that description, I'll turn it back to Mark.